My title of the talk is Square Pegs in Round Holes, and hopefully you'll see why that's the case as I move through the talk. So Australia has two HTA committees. The first one is the Pharmaceutical Benefits Advisory Committee. This committee has been in place for now over 60 years in Australia, providing advice to government about the safety, comparative cost effectiveness of medicines for listing on Australia's national formulary. Not so long in existence is MSAC, which has been in place now for 15 years, which has been providing a same sort of advice to government about non-pharmaceuticals. And so these two committees have been working for a very long time, not as decision-making committees, but rather as advisory committees to the Commonwealth Health Minister, who ultimately makes the decision as to whether something is going to be publicly reimbursed or not. But clearly the views of these committees are influential in determining the Minister's ultimate decision. Over the last couple of years, there's been a greater sense of need to merge some of the activities that happen in the pharmaceutical space with the non-pharmaceutical space, so that our Minister is actually receiving a much more coordinated set of advice, rather than advice that may at times be contradictory, and that has happened over the last few years. And so there was initially an attempt to try and apply some of the processes and rules that govern HTA around pharmaceuticals and apply them as a sort of cut and paste model to MSAC. But just quoting the famous philosopher Yogi Berra, who only probably the Americans in the audience actually know, he famously said, in theory there is no difference between theory and practice, and in practice there is. And I've changed that slightly to say, in theory there's no difference between HTA of drugs and other health technologies, but in practice there is. And so the idea of simply cutting and pasting something that applies to drugs doesn't work with non-pharmaceuticals, and that has been brought up through a number of the talks that we've heard through the last 2 days. But having said that, there is a recognition that there are some things that overlap, and there is certainly a need to have a better health technology assessment process that really encompasses all the elements of a patient's care rather than considering them in silos. So with that context, I just will now give you a little bit of overview about what I'm going to talk about in the next few moments. First of all, I'll just briefly describe the types of applications that come to MSAC. And then I wanted to take you through 3 very practical case studies of decisions that the committee has made over the last 3 years. I'm not putting them up because they're good decisions or bad decisions, but I think they both, all the 3 case studies illustrate different points. The first one is designed to illustrate an issue where the HTA committees disagree and how you resolve disagreement. The second is where there are multiple payers and one is the patient. And finally, the horny subject of removing items from the schedule. So MSAC looks at 3 sorts of applications. The first are therapeutic medical interventions, and they're interventions that are designed to directly improve a health outcome, like putting a stent in someone or providing a surgical procedure. The second type of application that MSAC looks at are consultative items. And they're items that are not just related to consultation by medical practitioners, but consultations by any health professional, counselling and other services. And the third type are investigative medical services, which means services where there are no direct health outcomes, but where the test or procedure has an intervention and a value attached to it through the provision of other information that is provided or helpful guidance for doctors in terms of determining their treatment paradigms. And increasingly we've recognised, and I've already touched on this, that there is this codependency between all these different types of interventions, and that it's very troublesome and often leads to perverse consequences when you look at them in isolation. And I'm using the term here, codependency, to be a very broad church to include anything where a therapy involving the use of one health technology to directly improve a health outcome, like a medicine or a medical device, is improved by the use of another health technology, like a pathology test or diagnostic imaging. And it's really that interaction happens because this second technology is better able to identify patients who will benefit from a new therapy or better able to monitor response to therapy. And so that term codependency is something that both our health technology committees are starting to try and pick up as we're going through health technology assessments in our own individual domains. So to give you some examples of the sorts of codependencies that can arise, a therapeutic medical service like RFA for treatment of liver tumours, for instance, and an investigative medical services, i.e. the tests that need to be done in order to determine who should be treated with RFA, both are independent services in some senses, but possibly should be best assessed as a package, and both require approval through MSAC, so therefore they're not traversing the domain between the two technology assessment committees. In contrast, an investigative medical service that requires funding through MSAC and a therapeutic pharmaceutical requiring assessment through PBAC do traverse the HTA divide between pharmaceuticals and non-pharmaceuticals. And an example here would be a molecular test to identify a patient who is suitable for a particular drug, like BRAF inhibitors and BRAF testing example as a contemporary example. This is often called the realm of companion diagnostics, and in doing these sorts of assessments across health technology assessment committees, I think we've identified some challenges, although they apply to other things as well. And the third example I'll give here is consultative medical services, where funding is approved through MSAC, so reimbursement for providing a service to a patient, and a therapeutic pharmaceutical which is funded through PBAC. And a very topical example here which alerted our own government to the importance of not assessing things in silos was an example where PBS reimbursement was provided for a drug for neovascularisation of the retina, and the total utilisation and financial cost of that was less than $10 million a year. And an unexpected consequence of that was that the fees that the government paid ophthalmologists went up to $40 million in 1 year as a consequence of that listing of the drug. Now, at the point of application, no one was actually considering that that service would be rendered by an ophthalmologist, and that ophthalmologist gets paid every time he does something, and he gets paid per eye, and people have 2 eyes. So these sorts of very trivial things were not picked up in the course of the assessments. Okay, so with that little background, I just wanted to provide now these 3 little case vignettes to give you possible talking points and discussion points later in the course of the session. So the first example is where HTA committee findings are internally inconsistent. So the pre-existing state here was an HIV drug which is publicly funded on the PBS for 4th-line use in patients with CCR5 tropic HIV. But the testing for CCR5 tropic HIV was not publicly reimbursed, and it wasn't publicly reimbursed because it actually predated an HTA process for assessment of tests. So the catalyst for change here was the pharmaceutical company sought to broaden the access for the use of the drug and applied for reimbursement for patients infected with CCR5 tropic HIV, but this time for patients who are treatment naive. So they decided to move the drug from essentially the last-line therapy to now to first-line therapy. So what happened as a consequence of that application was MSAC reviewed the test, and MSAC said the test wasn't any good. I mean, I'm paraphrasing here, but they basically found in their scientific judgment the test was not a good test. So therefore, PBAC rejected the drug for the new indication because the patient population couldn't be identified. But then that opened up the question of there was already a pre-existing listing of this drug on the PBS, and should that remain if the test itself is no good? Why would we be using exposing patients to a drug on the basis of a result from a test, and the test we don't believe in? And there was a lot of discussion here between PBAC, MSAC, the sponsor, the HIV service providers, as well as people who were doing the test. And at the net result, and this is not necessarily a right or wrong result, was it was decided to leave the drug on the schedule for the last line listing. And the reason for that was because the consequences of a poor performance of a test where there was no other drugs available was seen to be not as influential as it would have been had it been in the first line setting where a poorly performing test would have exposed a patient to a drug, a poor choice of drug. So this is a value judgment here. The test still remains non-reimbursable because MSAC could not make a positive recommendation to list a test where that test didn't pass the benchmark of scientific validity. So the test is currently still being reimbursed locally through various local arrangements for the small number of people who are still accessing this drug and test. The second case is supporting equity of access in a system where there are multiple payers and where the patient is one of them. So the pre-existing state here was Australia has a national cervical screening program which uses cervical cytology assessed by pap smears, and that's a very effective screening program for cervical cancer. The fee that is received for doing a pap smear is $19.60, and that's fully rebatable. The catalyst for change here was an application for reimbursement of a cell enrichment liquid-based cytology, so a new sort of test to detect abnormal cells in the cervix. So MSAC on this occasion looked at the test. MSAC said the test was safe and at least as effective as pap smears, so a scientific judgment here was positive. However, the new test was proposed to be reimbursed at the same cost as the pap smear, which looks like a simple cost minimisation argument and really should be a no-brainer. But market research and a lot of other information from patients and providers actually said the new test was inherently a lot more expensive. And so even if MSAC had made a positive recommendation to provide listing at a particular price at the $19.60, the likely scenario would be that the seller of the test would have actually charged a fee that was above $19.60. And our patients and patient input and providers' input said that if that happened, women would not go for pap smears because then they would be going for a test where they're not charged anything. Now they would be going for a test where they would be forced to reach into their pocket and pay for a test. So MSAC rejected the application on multiple occasions because of the likelihood of increased burden of co-payment to the patients would discourage participation in the National Cervical Screening Program and may even undermine the whole National Cervical Screening Program as providers moved their business more towards the liquid-based cytology. Then even the options for the patient who wanted to choose a pap smear, if that was still available somewhere, would shrink. So this is an issue, I guess, highlighting some of the dimensions of decision-making, which are not simply about scientific judgment and cost minimisation and economics, but some of the broader dimensions of decision-making. And my last case is an example of a removal of an item from the schedule. The pre-existing state here was that hyperbaric oxygen therapy has been funded for non-diabetic wounds on the MBS since 2003 on an interim basis. And you might think, well, interim basis, it's a very long time. That's a decade ago. Well, it's been sitting on the interim basis for a decade. So the catalyst for change was a scheduled interim review of the funding in 2011. So MSAC reviewed the evidence. MSAC advised the Minister that it didn't support continuation of interim funding based on scientific judgment of the quality of the evidence. The Minister discontinued the funding based on MSAC's advice in 2012, and then what intervened was a whole series of political interventions. So political interventions, local lobbying of ministers, and by the community of providers whose businesses were essentially dependent upon the fees for hyperbaric oxygen therapy. There was multiple considerations by MSAC that culminated in actually a National Senate hearing for the whole thing, which was really worth a very small amount of total money in the scheme of things. To date, the items have not been reinstated on the schedule, but Australia has an election in September, and politics can always continue to intervene here. So that's another example of where decision-making is not simply about the science and the cost-effectiveness and total financial spend. Politics clearly plays a major role in decision-making. So in conclusion, I hope in the last few moments I've talked about some of the consequences of codependency and illustrated how basically lots of the things that we've traditionally regarded as not codependent do have some elements of codependency, and that's an important dimension in decision making that is sometimes ignored. That we in Australia have started to, or are fairly mature in developing processes for establishing non-pharmaceuticals, but are also starting to merge the drug and non-drug interactions so that we're getting a much whole of technology assessment. That necessarily involves a much broader engagement of many stakeholders than it has done in the past. And finally, PBAC and MSAC have an excellent working relationship, which is really what we've found is very important in terms of providing coordinated advice to our health minister, so that the minister is not receiving conflicting advice from two of her designated committees. So with that, I'd like to conclude, and thank you very much for your attention.